I'm happy to be providing you this update on COVID-19 therapeutics for our December 2023 clinical forum. These are my disclosures. Today, I'm going to cover two topics. The first is a discussion about the updated WHO COVID treatment guidelines. This is the 14th version of those guidelines. And then I'm going to discuss some new data on rebound following treatment with nirmatrelvir ritonavir. This is a bit unusual because instead of showing you a lot of the data, I'm going to spend time going through these guidelines, and it's really just 2 slides, but worth spending the time to walk through this. And just to frame the discussion here, I want to set this up by letting you see how the guidelines are organized, and then we'll come back and talk about individual recommendations. So these guidelines apply to the population of people who have COVID-19 that has been confirmed by some diagnostic test, the antigen or nucleic acid test. And it characterizes individuals as having non-severe, severe, or critical COVID. And then it also characterizes the recommendations using standard criteria of strong recommendation in favor, weak or conditional recommendations in favor, and then, as you'll see on this next slide, weak or conditional recommendations against, and strong recommendations against. So let's look at the disease categories. Among the non-severe, these are people who have no signs of severe or critical disease, obviously, but they've now stratified them into 3 categories. Whether people have low, moderate, or high risk of being admitted to the hospital after a diagnosis of what is initially non-severe disease. Those in the high-risk category are people who are immunocompromised or recipients of organ transplant or stem cell transplant. Those who are considered moderate risk are those who are 65 years of age and older, as well as people with the usual pre-existing comorbidities such as heart disease, lung disease, diabetes, and the like. Interestingly, they did not include race or gender among the criteria for inclusion in the moderate category, even though we know from the initial epidemiology that men were at greater risk of progression than women, as well as in the United States, at least people who are African American or Hispanic were also at greater risk for COVID and for severe COVID. And then low risk is essentially everybody else. Those in the severe category are people who present with an oxygen saturation less than 90% on room air, although they do note that for people who have otherwise normal lungs, O2 saturations below 94% might be considered by many clinicians to already be evidence of severe disease. And then they also include signs of pneumonia, signs of severe respiratory disease among the people in this category. Then critical disease is fairly obvious. It's those who require life-sustaining treatment, such as invasive mechanical ventilation, those who have acute respiratory distress syndrome, a sepsis, or a septic shock. So in terms of the recommendations that are strong in favor of use of interventions, for those with non-severe disease, nirmatrelvir and ritonavir has a strong recommendation for use, but only in those with a high likelihood of being admitted to the hospital. That is, those who are severely immunocompromised or are organ transplant recipients. This is somewhat at variance with the guidelines in the United States, where even people who have moderate risk, those who are older and those who have coexisting medical conditions would be recommended for treatment with nirmatrelvir ritonavir. So that's an important point of distinction. And then looking at those with severe and critical disease, the recommendations are really the same for both categories of individuals. That is the recommendation for the use of corticosteroids, IL-6 receptor blockers, that would mean tocilizumab or sarilumab, or the kinase inhibitor baricitinib. Note that these may be combined And also note that what is missing from the strong recommendation is a recommendation for the use of remdesivir in those who have severe or critical disease. Now, moving to the weak or conditional recommendations, mostly these are situations where there's evidence for benefit, but the benefit may not be huge, and where there may be some counterbalancing factors. And so, for example, molnupiravir, it has a recommendation for use in people at high risk of admission to hospital, but it requires mitigation of strategies to reduce potential harm because molnupiravir is a mutagen, and it would not be favored over the use of nirmatrelvir ritonavir unless there was some reason that that combination could not be used, for example, where ritonavir is absolutely contraindicated. There's also a recommendation for the use of remdesivir in the outpatient setting, again, only for those with a high risk of progression, again, because nirmatrelvir would be favored over remdesivir if possible. And so it's a weak or conditional recommendation in situations where either nirmatrelvir ritonavir or molnupiravir would not be advisable. And then nirmatrelvir ritonavir is given a weak or conditional recommendation for those in the moderate risk category. And as I noted already, in the United States, at least, this is a category of people for whom we would really advocate treatment. Moving to those with more severe disease, this is where we see remdesivir appear with a weak or conditional recommendation. I think the basis for that sort of equivocal recommendation is the absence of compelling evidence for remdesivir providing a decrease in mortality or improving overall survival. Although, again, remdesivir use in the United States is pretty much standard of care for people who have severe disease. Let's continue down the chain now and looking at drugs in circumstances that have a weak or conditional recommendation against use. First of all, this includes the novel agent VV116, which is an oral formulation of remdesivir, not yet approved for use. And so this is recommended only in research settings. But interestingly, corticosteroids are given only a weak recommendation against for people with non-severe disease. There is some equivocal data about inhaled corticosteroids, but as we've discussed in previous versions of this program, some of the more recent data have been less compelling. And systemic corticosteroids showed evidence of harm in people who were not hypoxic in the large phase 3 randomized trial. So I'm a little puzzled that there wasn't a stronger recommendation against corticosteroids. And then you see that molnupiravir, remdesivir, and nirmatrelvir and ritonavir are all given weak recommendations against in people who have either just a moderate risk of progression or in those of low risk of progression. And fluvoxamine is recommended only in research settings, not for standard use. Now, looking at people with severe and critical disease, ruxolitinib and tofacitinib are recommended to be considered only if other immunosuppressive agents such as baricitinib and IL-6 receptor blockers are unavailable, since those have a strong recommendation for use in this setting. Curiously, ivermectin is not more strongly recommended against in these severely ill people. It is recommended only in research settings. I suppose that's because some of those clinical trials may still be ongoing. Likewise for convalescent plasma. And then there's a weak recommendation against remdesivir for those who are critically ill, because many of the studies have shown that by the time people have progressed to requiring mechanical intubation, in mechanical ventilation, that initial use of remdesivir at that time had little or no impact on disease outcome. And then lastly, those interventions that are strongly recommended against remdesivir and molnupiravir for non-severe disease and those at low risk of progression, colchicine, ivermectin. This is a new recommendation, strongly against based on newer data that we've reviewed previously, and convalescent plasma in this setting. A number of the other recommendations against have to do with the fact that the pandemic has moved on. So sotrovimab and casirivimab and imdevimab are no longer effective against the currently circulating strains. And we've known for a very long time that neither hydroxychloroquine nor lopinavir or ritonavir have any activity. These recommendations can be found published in the British Medical Journal, as cited here, and are well worth looking over and familiarizing yourselves with. Well, let's turn now to the question of viral rebound after nirmatrelvir ritonavir. Previous studies have shown various rates of either virologic or symptomatic rebound after treatment with nirmatrelvir ritonavir, which for convenience, I'm going to abbreviate NR here. And this has occurred in about 1 to 2% in the randomized phase 3 clinical trials, but has also been observed in patients receiving no treatment for COVID-19. And now, and a previously done prospective home-based study found rebound in about 14% of those receiving nirmatrelvir ritonavir. So this study that was published recently in the Annals of Internal Medicine by colleagues of mine here at Brigham and Women's Hospital and at Massachusetts General Hospital, Edelstein et al., led by John Lee and others, looked at an observational cohort in our healthcare system, which is a multi-center Boston-based system, and they enrolled 173 2022 and May of 2023. They found 72% of eligible participants had received nirmatrelvir ritonavir, and 55 had no antiviral therapy. The remaining people were not included in the analysis for one reason or another. Either they didn't have all the samples obtained or were enrolled too many days after their diagnosis of COVID to be included in this analysis. Participants self-collected anterior nasal swabs, which were tested for SARS-CoV-2 by PCR and by virus cultures. That's an important advantage of this analysis. They also completed a 10-item survey that was collected at the same time as the swabs in order to categorize their symptoms. The slide shows the data for those who were treated or not treated with nirmatrelvir ritonavir. And what you can see is that for those who did not receive therapy, there was a slow decay in viremia, but relatively few people seem to be rebounding. And that is true as well when you look at virus culture. By contrast, when you look at those who are treated, the decay is initially faster, but then there is this group of people who have a rebound of detectable virus in the nasal swabs, as well as those who have rebound in the culture positivity from the swab samples. One important point is the frequency with which the individuals were evaluated. And what you can see here in this slide is looking at different categories. There really didn't seem to be a statistically significant difference in the percent of people who had rebound if you compare those with and without immunosuppression, which may be a bit surprising. There was no difference by age or by vaccine history or by gender. There was a bit of a trend for a number of days from the initial positive test to start of treatment. The one area that was, or one variable that did come out as significant was the day of from symptom onset, not day of positive test, but day of symptom onset to initiation of treatment, suggesting that the earlier you started therapy, the more likely you were to rebound. But there were very, very few rebounders here. So these small numbers can limit the analysis somewhat. Then in a logistic regression analysis, where multiple variables were analyzed at the same time, you can see that really the only factor that emerged as significant was the use of nirmatrelvir ritonavir therapy, which had about a tenfold increased risk of rebound compared to not being treated. And then looking at the time from initial positive test result to a negative culture, you can see that certainly when looking at all of the individuals, that there was a faster time to negative culture for those who were treated with nirmatrelvir ritonavir. However, among those who had a positive culture, among those who rebounded, that their cultures took longer to clear because they became positive once again. So it's a bit of a confusing story in a sense that overall you actually cleared your cultures faster by getting treated, but if you were among the subset who rebounded, then your cultures remained positive for longer than those who didn't get treatment. There are some limitations to this study. As I mentioned, it's observational and had a relatively small sample size, and there was only one person there were limited numbers of people in the untreated group who had rebound. This has to be taken into context with other studies. So, for example, in this study from Anderson and colleagues, which is a report from the phase 3 clinical trial, they found no difference in the rates of viral rebound between those who were treated or those who received placebo. But note here that the frequency of sampling is much less intensive than in the more recently published study. And this may explain why the Edelstein study found that there was a greater risk of rebound compared to no treatment as opposed to what was seen in the phase 3 trial. But the same group of colleagues of mine also previously had an analysis of a placebo group in one of the monoclonal antibody studies and showed that rebound was really quite frequent. Overall, about 20% of people rebounded, which is similar to the rate of rebound that was seen in their most recent nirmatrelvir study. And so rebound seems to be a pretty frequent phenomenon even in untreated people. In this context, it's important to note that the most recent study is not a randomized trial. So there may have been a significant bias in who received treatment as opposed to who did not receive treatment, even though they attempted to control for those factors. They just didn't have enough numbers to be able to do a propensity-weighted balancing of the groups. So in conclusion, viral rebound clearly occurs with nirmatrelvir ritonavir treatment, but it's not reliably associated with the return of symptoms, so people may be rebounding and not be aware of it. Rebound was associated with positive SARS-CoV-2 culture and therefore could be associated with transmission. Nevertheless, the overall time to culture negative was similar in treated and untreated groups when you looked at all of the participants. And for persons at high risk of severe COVID-19, it's clear that the benefits of treatment with nirmatrelvir ritonavir still outweigh the risks. So I look forward to the discussion.